Swastiastu. So today we're going to present our student project about clinical trial study.
Okay, so the background is the clinical study evolution has gone through very long but extremely interesting stages. Clinical studies alludes to all experiments done on both healthy and ill people. Clinical study can be divided into two types, which are observational studies and interventional studies. Observational examination plans incorporate nature plans, cross-sectional, case control, case hybrid review, and planned partners. The purpose of the study is to understand the importance of clinical trial study by analyzing the selected article. The benefits from the study is better literature review and better understanding about clinical trial studies.
So I will explain about the introduction. It's difficult to determine whether resveratrol is beneficial to treat AD or not. Another study has reported that the mixture of low-dose resveratrol, glucose, and malat, or RGM, showed good effect for cognitive function without any significant side effect when given to AD patients that already treated with stable dose of donepezil. This study had two specific goals. The first one was to test RGM efficacy and safety in AD patients by conducting trials with exact replication. The second one was to assess efficacy at 12 months. The hypothesis of this study was that RGM could reduce AD progression significantly and have significant beneficial effects.
So for the clinical trial design used in this study was a randomized double-blind placebo-controlled parallel design, a pilot study. So a randomized control trial is a study or experiment performed under control conditions with random allocation of comparison and intervention groups, which the trial participants are randomly assigned to either a treatment or control group. More about randomization will be thoroughly explained by my friends later. Next, the double-blind study is a study that blinded the researchers and subjects for the treatment allocation. And the placebo control, it helps to differentiate outcomes because of the intervention from outcomes because of the other factors. This design is unethical to use if there is an effective standard treatment that exists. Therefore, the placebo control design can only be used if there is no effective treatment. In a parallel design, subjects are randomized to one or more study groups. Each study group then will be allocated different intervention. Then each participant will remain in the designated group for the duration of the study after the randomization. Then next, the pilot study is a small-scale version of a planned study conducted with a small group of participants who are similar to those who will be recruited later in a large-scale study. Next. So this is the profile study of a randomized double-blind placebo-controlled trial of resveratrol with glucose and malat or RGM to slow the progression of Alzheimer's disease, a pilot study. It is shown in the table of figure below. So as we can see in the table, the researchers started the process of sampling by assessing the eligibility of each sample, and then after excluding and terminating some of the sample, the researcher then start to randomize the sample into control group and intervention group, which then each will be analyzed. By the end, a total of 16 sample is being analyzed in the intervention group and 13 sample in the control group.
So for the eligibility criteria for the study are primary inclusion criteria, where a possible or probable Alzheimer's disease diagnosis according to the National Institution of Neurological and Communicative Disorder and Stroke Alzheimer's Disease and Related Disorder Association, where their age range must be 50 or older with MMSE score 12 to 26. The participant must be living in the community and are under stable medical condition and are stable use of non-excluded medications. This participant had supervision available for administration of study medication and also must be availability of a study partner to accompany subjects to all scheduled visits and complete information-based assessment. Participants must be able to complete baseline assessment in English or Spanish. As a consequence, were able to ingest an oral agent. For the exclusion criteria, active liver or renal disease with an active life-threatening neoplastic disease were also included in the study. These participants were under use of another investigational agent within 2 months of the screening visit. Moreover, they were with a history of clinical significant stroke, current evidence or history in the past 2 years of seizure, head injury with the loss of consciousness, and or immediate confusion after the injury, current DSM-4 diagnosis for major psychiatric disorder as well as blindness, deafness, language difficulties or other disability that may be interfere with assessment. So for the setting and location used in this study are subjects were randomly assigned to the placebo or treatment group which they had to follow up at 3, 6, and 12 months after the enrollment process. This enrollment began in January 2007 and completed in September 2009. 35 participants from each group were expected to require to accomplish 80% power to identify a difference in mean Alzheimer's disease assessment scale, cognitive subscale, turn between active and placebo group from the analysis performed based on fundamental available data at the time. Enrollment target was set to be 100, which is 50 per group to allow for attrition. 32 enrollment were randomized, with the actual enrollment count was 39 of them. Clinical assessment, cognitive behavior were administered at baseline and every follow-up visit by participant. All the subjects were treated with RGM or placebo with sum of 12 months.
Okay, so for the intervention, there were two groups in the study. The first one is the intervention group, and the second one is the control. The treatment for the intervention that was given to the group is regimen consisting 5 gram dextrose, 5 gram malate, and 5 gram resveratrol per dose, and prepared in liquid form, dissolved in unsweetened commercial grape juice, 15 milliliter volume twice a day. Meanwhile, the control group was given a placebo that contained sucrose in lemon juice that indistinguishable by color and taste. So it was already blinding to reduce the bias due to conception of the patient and the clinician. Next. For the specific measurement, there were two specific measurements, the primary and the secondary outcome. For the primary outcome in the study, show the change of cognitive quotient of every group by using a psychometric instrument named ADAS, Alzheimer's Disease Assessment Scales, cognitive subscales, and the study evaluated the memory, attention, reasoning, language, orientation, and the praxis of the patient. The score range is 0 till 70, and the lower scores indicated the improvement of the cognitive, while positive changes score mean the worsening of the cognitive. And there were some points measured in the secondary outcome. The first one is MMSE or mini mental state examination. It means that the higher scores indicated a better cognition, and the positive change mean the improvement of cognition. And the second instrument is Alzheimer's Disease Cooperative Study Activities of Daily Living to measure the functional of the patients in activities daily living. The increase of measurement is mean a better function, and the positive change mean improvement of the function. And the third one is to assess the behavior. The study was used a neuropsychiatric intervention or NPI. The higher scores indicated worse of behavior, and a positive change mean a worsening of behavior of the patients. And the last one for the secondary outcome was using Alzheimer's Disease Cooperative Study Clinical Global Impression of Change. The instrument is also used to measure the secondary outcomes, but it was not explained well in the study, neither the interpretation and nor the range. Next.
Next, I will explain about the sample size determination method. So the sample used in the study were patients from Mount Sinai Alzheimer's Disease Research Center. And for the sample size determination method itself is not reported in the published report. Next. Interim analysis is done as the data accumulates to determine whether the study should be ended or continued. This study reported that they do the interim analysis quarterly, and the interim analysis is then reviewed by an independent data and safety monitoring board. Next.
Okay, I'm Mulia. Okay, this is about randomization type. The research and study subject don't know who got the experimental treatment and who got the placebo. The study is using randomized double-blind placebo control method. This is a pilot study with placebo control parallel design. Randomization type was centrally generated to determine group assessment as with equal probability of assignment to drug and placebo. After that, safety measures include clinical and laboratory indicator. The study was approved by the local institutional review board. Okay, randomized control trial can determine whether there is a cause and effect relationship between intervention and outcome. In randomized control trial, trial participants are randomly assigned to either a treatment or control group. Randomization eliminates the potential for systematic error or bias. The group characteristic difference that can affect the outcome can be minimized by doing randomization, therefore providing the SARS evidence regard the export or intervention impact on the outcome. From the next, okay, from the picture, the reader get information that subject were randomly assigned to the treatment or placebo group and follow up at 3, 6, and 12 months. Actually, enrollment sample was 39, of which 32 were randomized. Analyses were based on intention to treat population, including all randomly assigned participants with at least one post-baseline observation.
So here's the procedure until intervention is given. Firstly, subjects were prepared with written information consent before the enrollment. Then after enrollment, they were assessed for eligibility based on the primary inclusion and exclusion criteria. The subjects who passed the screening then followed a randomized trial assigned either to treatment or placebo group. For the intervention itself, the treatment group took an actively treatment regimen twice a day, and meanwhile the placebo group received the sucrose and lemon juice that were indistinguishable by color or taste. Then the follow-up was done at 3rd, 6th, and 12 months and reviewed by an independent data and safety monitoring board. For each visit, the subjects received vital sign assessment, physical and neurologic examination. Then both primary and secondary outcomes using change scores on ADAS Cognitive, MMSE, ADCS, ADL, or NPI were assessed by trained clinicians who were blind to participants' treatment. The safety measures include clinical and laboratory indicators, furthermore including a standard reporting of any adverse events of endorsement of items from a symptoms checklist that directly inquired about known side effects of the agents. The study staff was contacted by the informant regarding every data collected at each visit, and for the withdrawn subjects, the early termination was scheduled similar to a baseline visit. Next. So the randomization of the study was centrally generated, means the clinician contacted the administration center, then giving the prognostic factors, for example, such as age and sex. Then the details were filed straight into customized database package to set up the allocation. So from the based on the study, there is no further info regarding the subjects who did the randomization, subject inclusion, and determined subject allocation. But there was others contribution regarding to the conception and design making of the study created by MS, initial MS, HG, and JN. Next.
For the statistical method to compare the primary and secondary result in this study using a Fisher-Exa test for categorical data and Wilcoxon side rank test for continuous data. The Fisher-Exa test is also used in examining the difference of rate of adverse event. Then this study also use a generalized estimating equation for examining the rate of change outcome in a group difference. This study also used logistic regression to examine the proportion subject reporting worsening on the ADCS CGIC. For the safety analysis, this study used a summary listing of IS become a reference. And then this study also use intention to treat based on the line place was baseline observation. For the p-value in this study is 0.05, and this study is analyzed with Stata 13. Result of the study. Primary result for in this study is there were 29 subjects that assigned that 16 in the treatment group and 13 in the placebo group. All the subjects were randomized into the treatment and placebo group with the same characteristic on age with mean 80, and on the gender there are 56.6 of female, and education with mean 15. For the secondary result, we can see the change score from baseline ADAS cognitive in the third 6 and 12 month of control. That can we show in the table. For the significance, the generalized estimation equation showed that there was a change of estimate rate in the treatment group. For the impact, NPI was lower in the treatment than the control group. In the control group, ADAS-Cog increased with P 0.05 and MMSE decreased with P 0.003. At the third month, subjects in the treatment group performed worse than in the control group as measured by CGIC with percentage 15.4% versus 50%. At the 12-month visit, there was no statistically significant difference by CGIC in the treatment group. Next.
Okay, next I will explain about study limitation, bias, source, and precision problem. First one, the study limitation as discontinue study due to difficulties in recruitment of the subject and keeping the study product stable, underpowered to detect and difference in clinical outcomes. Such limitation may come from the long period of study, difficulty in permission to recruit such subject. Furthermore, this study controlled bias source by design by restricting subjects that may have a confounding factor, for example, anticholinergic drugs. And the next, the generalizability of a study is the applicability of the result to other circumstances that differ from the participant of the study. The study states that the sample used in the study consists of a typical group of Alzheimer's disease patient with a combination of function in the mild moderate range. There is no further information stated in the published report regarding the generalizability.
Today it was supposed to be chapter 3, the conclusion. So we'll talk about the conclusion. So basically, the study aims to evaluate safety, tolerability, and efficacy of oral pastoral glucose and malate to slow down Alzheimer's disease progression. The study of the clinical trial design is a pilot study with placebo-controlled trial design. The sample taken is only able to reflect Alzheimer's patients in bacterial area, and the method to determine the sample is not reported. The study has detailed eligibility criteria and detailed intervention method. Randomization method using double-blind study is well controlled, but the authority who did the subject inclusion, randomization, and allocation is not mentioned. Primary and secondary results measured by several indicators is presented well. Statistical method is also presented well. Authors Also understand the limitation, bias, and the other precision problems that may occur. To end this presentation, I would like to say Om Santi Santi Om.